Yes, I want us to look at the basically the assessment, but talk about respiratory disorders. Here we are going to look at now that comprehensive approach to just manage respiratory issues that are affecting a patient. And we have to give it a very comprehensive approach, which will ensure that now we maintain adequate oxygenation for our patients, promote airway clearance, support the overall respiratory of our patients. So first things we just look at the subjective data. In the morning, we're talking about subjective, objective data. Subjective data, what the patient verbalizes, usually be very key. The characterization of the patient symptoms, the history taking, which will help us now to anticipate the needs of our patients and the plan of care, like we talked in the morning. Of course, when we talk about subjective data, want to look at the history of the cough, the sputum, the color of that, the consistency, the amount. We want to look at the dyspnea, where we talk about, of course, dyspnea, those difficulties in breathing. And when focusing now on the, or when evaluating the dyspnea, you want to look at the characteristics of that dyspnea. Is it acute? Is it chronic? I believe we know how to differentiate between acute and chronic, whether it was of sudden onset or it is of gradual onset. Is it progressive? Is it recurrent? Does it worsen when one is walking? So it is important you get to evaluate that dyspnea. How is dyspnea significant to respiratory diseases? So many diseases, of course, can present with dyspnea. And this is where, again, now your history taking is very crucial. Dyspnea can be presented in respiratory disorders, and dyspnea can be presented by cardiovascular related disorders. So the way you now go about your history taking will determine whether you will have the accurate diagnosis for your patient. Chest pain or chest tightness. The characteristics of that pain. Is it sharp pain, dull, stabbing, aching? Is it localized? How does it radiate? It's all that is information that you need to evaluate in patients with respiratory disorders. And more especially, chest pain is a very common occurrence in respiratory diseases. It can be as a result of inflammation, can be as a result of an infection, can be as a result of trauma to the chest, or changes that are affecting the lungs, the pleura, or the chest wall. So understanding the cause, the type, and the characteristics of that chest pain will help you with the management of the patient. We have various cause of chest pain, like we have in pleuritis. We'll talk about what brings about that chest pain, in pneumonia, in pneumothorax, in tuberculosis, in bronchitis, in lung cancer. All those are diseases where you can get to see chest pain. The characteristics of the pain, which you have just mentioned about, the location, localized to one side of the chest or radiating to the shoulder or to the back. The aggravating factors like deep breathing, coughing, sneezing, the relieving factors. There's some chest pains that can be relieved by positional changes like sitting upright, splinting the chest, associated symptoms like chest pain that's accompanied by cough, by fever, by sputum production, is some of the things that you can get to check. On your assessment, observe the patient for respiratory distress. Are they using accessory muscles to breathe? What is the rate of the respiratory rate, the rhythm of respiration? Can help you to evaluate that. Check the vital signs, the temperature, the oxygen saturation levels, the blood pressure, the heart rate, because all this can be to the chest pains. Auscultate for the breath sound. The red flags that can be as pain, which can be a red flag. Cyanosis, patients experiencing cyanosis, chest pain, and then cyanosis, that's a red flag. Hypotension, on checking your blood pressure. You can evaluate that as you do your pain assessment. Managing the pain, you can encourage splinting of the chest. You can give analgesics. You can do warm compresses, positional changes, encouraging deep breathing or the past lip breathing, maintaining positional changes, the high Fowler position, or giving oxygen therapy for hypoxemic patients. That's when you take the oxygen saturation, see the patient is becoming hypoxic. It's very important. And again, eventually you just have to manage the underlying cause of the chest pain, whether it's related to a disease like pneumonia, TB, then you can give the requisite antibiotics. Or you can, if it's an inflammation, you want to give the bronchodilators or the steroids. Chest tube insertion in cases of pneumothorax. So all that is what you can evaluate in chest pain. Then there is cough, which is again a very common occurrence in respiratory related conditions. So evaluate the type of cough. We have dry cough, which is the non-productive cough. That means there is no sputum, but always very irritating. We have the productive cough, which produces sputum. We have the paroxysmal cough or the spasmodic cough, which is sudden, forceful bouts of coughing, chronic cough, which has lasted for a prolonged period of time. So evaluate what is the characteristic, how is this cough presenting. Like now, the cases of viral infections, asthma can always present with a dry cough or non-productive cough. Cases of bronchitis, pneumonia can produce wet cough. Cases of bloody cough, what we refer to as the hemoptysis, can be presented in cases of diseases like TB, lung cancer, which present with bloody cough or hemoptysis. So evaluate this cough, its associated factors, the consistency, the amount, the color, any occupational exposure to any harmful substances, history of coughing, a history of smoking, be it current or past smoking, active or passive smoking. All those are part of what you need to collect as part of your history taking. The significance I've just mentioned. A dry cough can be a respiratory infection. Bloody cough can be an indicator of lung cancer, can be an indicator of TB. And we'll be talking about this when we'll come to the actual conditions. We'll still discuss those types in detail. Hemoptysis, which I've just mentioned, bloody cough, that's hemoptysis. So you evaluate the patient. Where is the source of this blood? Is it from the lungs? Could it be from the GI system? Could it be from the upper airway? Because all this, the source will be an indicator of different things. Epistaxis, which will be from the upper airways. hematemesis, which will be from the GI system, or straight from the lungs. So you need to evaluate that any associated factors, burning sensation in the chest before bleeding, salty test in the tongue, presenting with shortness of breath. Evaluate your patient if there's been a history of recent chest trauma or respiratory treatment. If there is prior history of respiratory infection, you have to evaluate your patient for that. That's on history taking. Then on physical examination, which again now follows after your history taking, which is very key. Now talk about physical examination, very essential again to help you detect abnormalities within the breathing patterns of the patient, lung expansion, or just general gaseous exchange. So, of course, physical examination, the IPPA, the inspection, palpation, percussion, and auscultation should be done in that order. Again, on inspection, just I give you a rough overlook of it. On inspection, of course, you want to look at the general observation of the patient. You just have to look the level of consciousness, the alertness of the patient. Remember that hypoxia. What's hypoxia?
Low oxygen in tissues.
Yes, low oxygen in tissue. So, if there's low oxygen levels in the tissues, then it's going to cause restlessness. It's going to cause confusion. Look at the facial expression of your patient. Is there element of distress? Is there anxiety? Is there, cyanosis? So, still on your physical examination, the respiratory rate, the rhythm of the patient, the effort of breathing. Is the patient using accessory muscles? Look at the chest wall movement. Is it symmetrical? How is the chest wall expanding? Are there any deformities? The skin, the nails, where you now check for things like clubbing, which can be seen in chronic hypoxia. You see there the clubbing of the fingers usually presents in cases of chronic hypoxia. Very, very important. Still, you go on palpate, where you now assess the chest expansion, the tenderness, the vibrations, percuss, again, which will help you to assess underlying tissue density. During percussion, you can hear the resonant sound, which is normal lung tissue air field. If it's dull, could be there is pleural effusion, hyperresonant in cases of pneumothorax, and we'll be discussing these conditions, or not as much as mentioning them. Then lastly, now you get to evaluate, to auscultate. So, which will now you get to hear the air movement through the trachea and the lungs. And I know that the abnormal sounds, the adventitious sounds, the crackles, the wheezes, the rhonchi, you need to distinguish all those sounds, the adventitious sounds. What are the rackles? How do you tell that these are rackles? This is wheezing, which is always continuous, musical in nature. The rhonchi, which is low pitched, snoring like type of a sound. So get to evaluate that. So is there central cyanosis? Is jugular vein distension, which will be a sign of a cardiac dysfunction.